Welcome to this pediatric nursing masterclass on coarctation of the aorta. This comprehensive guide covers high-yield content, previous year questions, and visuals to help you prepare for exams like NORCET and RRB. What is coarctation of the aorta, or COA? It is a congenital heart defect defined by a localized narrowing or stenosis of the aorta. This narrowing typically occurs near the insertion of the ductus arteriosus. The term coarctation comes from the Latin coarctere, meaning to press together or tighten. COA accounts for 5 to 8% of all congenital heart defects and is more common in males. It is highly associated with Turner syndrome, where approximately 15 to 20% of patients have COA. It is also often associated with a bicuspid aortic valve. Coarctation is classified based on its relation to the ductus arteriosus. Preductal or infantile COA occurs proximal to the ductus, is more severe, and presents early with heart failure. Postductal or adult COA occurs distal to the ductus and is often asymptomatic, but presents with classic high blood pressure in the arms and low blood pressure in the legs. This visualization highlights the narrowing in the descending aorta. Notice how the coarctation restricts blood flow to the lower body, while blood flow to the head and upper limbs remains unimpeded or is increased. The coarctation creates a pressure gradient. Proximal effects in the upper body include high blood pressure in the arms and bounding pulses. Distal effects in the lower body include low blood pressure, weak or absent femoral pulses, and cool extremities. In infants, critical COA usually presents shortly after the ductus arteriosus closes. Signs include congestive heart failure, severe acidosis, and rapid deterioration. Immediate treatment with prostaglandin E1 is often required. In older children, COA is often asymptomatic, earning it the nickname silent killer. It may be an incidental finding of hypertension. Symptoms can include headaches, nosebleeds, and leg pain with exercise, which is known as claudication. The hallmark sign of coarctation of the aorta is blood pressure disparity. The systolic blood pressure is significantly higher in the upper extremities, or arms, than in the lower extremities, or legs. Pulse assessment reveals bounding pulses in the upper extremities. Conversely, the lower extremities, such as the femoral, popliteal, and pedal sites, will have weak or absent pulses. This results in a radiofemoral delay, where the femoral pulse is delayed compared to the radial pulse. Let's review these key points. The classic BP finding is high in the arms and low in the legs. The associated syndrome is Turner syndrome, and the pulse character in the legs is weak or absent. Diagnosis involves measuring blood pressure in all 4 limbs. A systolic pressure difference greater than 20 millimeters of mercury between the upper and lower extremities is diagnostic for COA. Remember to use the correct cuff size for accurate readings. A chest X-ray can reveal rib notching, a classic sign in older children. This is caused by enlarged intercostal arteries, which form collateral circulation to bypass the aortic obstruction, eroding the undersurface of the ribs, usually from the 3rd to the 8th. Another distinct CXR finding is the figure of 3 feet sign. This appearance results from the dilated aortic arch, the indentation at the coarctation site, and the post-stenotic dilation of the descending aorta. The echocardiogram is the gold standard for initial diagnosis. MRI and CT angiography provide detailed anatomical visualization for surgical planning. An ECG may show left ventricular hypertrophy in older children due to long-standing hypertension. To quickly review diagnostics, the CXR signs are rib notching and the figure of 3 sign. The key ECG finding is left ventricular hypertrophy. Medical management for critical COA in infants involves prostaglandin E1, or alprostadil. This drug keeps the ductus arteriosus patent, allowing blood to bypass the narrowing and perfuse the lower body until surgery. A key side effect is apnea, requiring close respiratory monitoring. Surgical repair is usually performed at 3 to 6 months of age. The goal is to remove the narrowed segment and restore normal blood flow. The common surgical approach is a left thoracotomy, an incision on the left side of the chest. The most common surgical technique is resection and end-to-end anastomosis. Another method is subclavian flap aortoplasty, which uses a flap from the left subclavian artery to widen the aorta. A key disadvantage is the potential sacrifice of blood flow to the left arm. Interventional treatment, such as balloon angioplasty, is preferred for recurrent coarctation or in older children and adolescents. A catheter is used to inflate a balloon at the narrowing site. It is generally not preferred for neonates due to the risk of aneurysm formation. Preoperative nursing care focuses on monitoring perfusion by checking forelimb blood pressure and pulses. Administer prostaglandin E1, monitoring closely for apnea, and manage heart failure with diuretics and digoxin. Provide high-calorie, low-volume feedings. Postoperative care prioritizes strict blood pressure control, as hypertension is a common complication. Medications like esmolol or ACE inhibitors are used to prevent stress on the surgical suture line. Neurochecks are essential to monitor for rare spinal cord ischemia. Rebound hypertension is a dangerous postoperative complication characterized by a paradoxical high blood pressure immediately after surgery. It is caused by altered baroreceptor reflexes and stress hormones. Aggressive management is required to protect the repair site. Post-coarctectomy syndrome, or mesenteric arteritis, results from a sudden increase in blood pressure to the abdominal arteries, causing inflammation. Symptoms include severe abdominal pain and vomiting. Strict postoperative blood pressure control is the key to prevention. Let's review management keywords. Prostaglandin E1 is the drug used to keep the ductus open. Rebound hypertension is the critical post-op complication. The common surgical approach is thoracotomy. Question 1. Which assessment finding is most characteristic of coarctation of the aorta? The answer is C. BP higher in arms than legs. This reflects the pressure difference caused by the aortic narrowing. Question 2. Rib notching seen on a chest X-ray in a 10-year-old child is indicative of what? The answer is B. Coarctation of aorta. This classic sign is due to collateral circulation eroding the ribs. Question 3. Coarctation of the aorta is most frequently associated with which genetic syndrome? The correct answer is B. Turner syndrome, as up to 20% of those affected have COA. Question 4. When assessing a newborn with coarctation of aorta, the nurse expects the femoral pulses to be. The answer is B. Weak or absent, due to restricted blood flow to the lower extremities. Question 5. Which medication is administered to a newborn with critical coarctation to maintain ductal patency? The answer is B. Prostaglandin E1, which keeps the ductus arteriosus open. Question 6. Following surgical repair of COA, the nurse should prioritize monitoring for which complication? The answer is B. Hypertension. Rebound hypertension is a dangerous postoperative risk. Question 7. The figure of 3 feet sign on a chest X-ray is pathognomonic for. The answer is B. Coarctation of aorta. This is formed by the dilated arch, coarctation site, and dilated descending aorta. Question 8. A child presents with severe abdominal pain 3 days after COA repair. The nurse suspects. The answer is B. Mesenteric arteritis, also known as post-coarctectomy syndrome. Here are the golden keywords for your exams: BP disparity, figure of 3, rib notching, and Turner syndrome. This slide provides a brief summary of the presentation content. Thank you for joining this masterclass. Continue your revision and consider reviewing the recommended reading material. Our next topic will be tetralogy of Fallot. Thank you. Remember, consistency is key to cracking your exams.